Hello guys, welcome to podcast 6 of Let's Revise MBBS, and today we are going to see some physiological changes in the mother which happen during the course of pregnancy. We are going to particularly focus on GI system, RS system, renal and reproductive systems. Okay, so before starting, let me answer the questions that I asked you yesterday. So the LMP question which I gave you, in that question I said that the EDD was 15th March 2020, right? And she was having the cycles of 31 days. So her LMP would be 7th June 2019. Okay, we can cross check it. In 7th June, add 9 months. It will be March. Okay, so 7th March. In 7th March, add 7 days. Okay, if you add 7 days, it is 14th March, and you add 3, so it's 17th March. Yeah, sorry, I gave you LMP as not as 15th March, as 17th March. Yeah, so it matches. So the LMP would be 7th June 2019. Okay, and for the vaccines, okay, vaccines which are safe in pregnancy are rabies vaccine, influenza vaccine, hepatitis vaccine. These are safe. But some vaccines like yellow fever, polio, and these are live vaccine, but still these can be given if she is traveling to certain endemic areas. Like if she is traveling to Africa, she should be given yellow fever vaccine. Okay, and other vaccine like chickenpox, smallpox, BCG, all these vaccines should be contraindicated. These vaccines should not be given, right? So now let's move on to our today's topic. So in the GI system, we will mainly talk about vomiting in pregnancy. So vomiting in pregnancy can be either simple vomiting, which we call as morning sickness, or it can be hyperemesis gravidarum. Right? But what is the cause of vomiting? Why does the female gets vomiting during the pregnancy, especially during the first trimester? So the main hormone responsible for this is HCG. Okay, other hormones like estrogen, progesterone, thyroxine are also said to play a role in this. Some mechanisms I read about this was that HCG stimulates the area postrema, which is the vomiting center, and induces vomiting. And progesterone mainly is a muscle relaxant, so it relaxes smooth muscles of the stomach. Also it relaxes the cardiac sphincter, and that's why it plays a role in vomiting. But the overall main role is played by HCG. Okay, and you see that this vomiting is it's maximum during the first few weeks, but then after 14 to 16 weeks, she is normal. The female is normal. Why is it so? Because we had discussed that the HCG peaks at around 6 to 10 weeks, and then its level starts dropping, and it comes down almost to a very low level at the end of the 16th week. That's why all the symptoms of vomiting resolves after 14 to 16 weeks. Okay, now coming on to the hyperemesis gravidarum. So the name itself suggests that hyper is something which is very severe. It has very severe adverse effects. Emesis is vomiting, and gravidarum is during the pregnancy. So what is severe? There is significant weight loss. So homework here, tell me what is significant weight loss. Okay, second, she can get alkalosis, then hypokalemia or dehydration. So if the female is having severe vomiting along with any of these adverse effects like significant weight loss, alkalosis, low potassium levels, dehydration, then we call it hyperemesis gravidarum. Okay, what is the risk factor particularly for this condition, hyperemesis gravidarum? So if there is high amount of HCG than in the normal pregnancy, like in molar pregnancy, in twin pregnancy, it can lead to hyperemesis gravidarum. Then if there is higher amount of estrogen, when will the estrogen level increase more than the normal pregnancy? If the fetus is female, she will also secrete estrogen, and further the estrogen in the mother's serum will be increased. And if there is high level of thyroxine. Okay, so what are the complications of this Hyperemesis Gravidarum. First of all, whatever food she is eating, she will not be able to consume it, and all other adverse effects that we saw will be seen. But particularly 2 vitamins are deficient. The first one is thiamine. So thiamine deficiency may lead to Wernicke's encephalopathy, which has a triad of GOA. G is global confusion, O is ophthalmoplegia, and A is ataxia. And also vitamin K is deficient, which may lead to hypoprothrombinemia. Okay, for management of this condition, we mainly use antiemetics, which are H1 blockers like promethazine and doxycycline. We can also use prokinetics like metoclopramide, and we supplement the vitamins like thiamine and vitamin B6. Okay, that was about Hyperemesis gravidarum. Coming on to the next, in the same system we have liver. So the size of the liver remains normal, but the enzymes are slightly decreased. They may remain normal, but the enzymes are mostly reduced, except alkaline phosphatase. Okay, the level of alkaline phosphatase rises during pregnancy. This is because placenta also secretes this hormone. Okay, so there is also cholestasis, which is mainly due to estrogen, and there is gallbladder atonicity, which is due to mainly progesterone. If these 2 things combined with high cholesterol level in the mother, like if she is obese or she is having high cholesterol level, she is predisposed for having gallstones. Okay, right. Now moving on to the next system, that is respiratory system. So in respiratory system, you have to remember, you have to understand two things. First, that the residual volume decreases. Why does it decrease? Because uterus is growing in size, it pushes the diaphragm, and overall the vertical diameter of the thoracic cavity reduces, and that's why residual volume decreases. But in pregnancy, the transverse diameter increases. It increases by around 2 centimeters. That's why tidal volume increases. Okay, these 2 things are important. Tidal volume increases, but residual volume decreases. By these 2 things, you can derive the rest of the volumes or capacities. Like suppose I ask you, what happens to the inspiratory reserve capacity? So what is IRC? It is tidal volume plus inspiratory reserve volume. Okay, inspiratory reserve volume remains same, it does not change, but tidal volume increases, right? Therefore completely IRC will increase. If you see as a whole, inspiratory reserve capacity, it will increase. Okay, let's see about FRC. FRC is functional residual capacity. So it has RV in it, right? It has residual volume. So if residual volume is decreasing, FRC will also decrease. Okay, in that manner you can derive that which capacities will remain same, which will increase or which will decrease. Right, moving on to the next system, that is renal system. So glycosuria is quite common and is normal in pregnancy. Why is it so? It is mainly because of 2 reasons. First, as we saw in the previous podcast, that there is increase in level of HPL, which is human placental lactogen, and this is an anti-insulin hormone. It increases the glucose level in blood. Okay, so ultimately there is higher amount of glucose reaching into the glomerulus and getting filtered. And also I'll tell you in the next podcast that in the hematological changes there is increase in blood volume by around 40 to 50%, and that's why the blood flow to the kidney will also increase. So both ways there is increase in load of the glucose in the kidneys, and also the threshold level for the glucose reduces. So due to these 2 reasons there is glycosuria in pregnancy. Okay, also if you talk about bladder capacity, it will obviously decrease because the uterus is growing in size, and there can be hydroureter mainly on the right side. Why? Because uterus is growing more on the right side. Why? Because on the left side there is colon, there is rectum. That's why it doesn't have enough space to grow on the left side, That's why it enlarges on the right side, thus causing hydroureter. Okay, moving on to the next system, which is a reproductive system. So in reproductive system, uterus. First, initially in the non-pregnant state, the weight of the uterus is around 50 to 100 grams. 50 grams, yeah. But in pregnancy, it increases to 1 kg. So it is almost 20 times increase in weight. In volume, it is initially the volume is around 10 ml before the pregnancy, and in the pregnant woman it becomes to 5 liters. So there is massive stretching and massive increase in volume as well as weight. Moving on to the cervix, there is proliferation of the endocervix and thus it moves outwards. So the squamocolumnar junction shifts slightly downwards, and during the pregnancy this cervix is closed. The os of the cervix is closed by the mucus plug because of progesterone, but as she arrives, as the time of delivery arrives, this mucus plug is released along with some bleeding, and this process or this thing is called as show, SHOW, show. Okay, now changes in the vagina. There is increase in daughter-line bacilli, and therefore there is more lactic acid produced, and the pH is decreased. pH comes down to around 3.5 to 4, and that's why it prevents the infection by other bacteria, pathogenic bacteria. And the changes in the ovaries. So since we saw that there is high amount of HCG, and HCG has two subunits, alpha and beta. The alpha subunit is similar to that of LH and FSH. So HCG has some common function with LH and FSH. So if HCG increases, it also functions somewhat like LH and FSH. It stimulates ovaries, and there can be theca luteal cysts. So these theca luteal cysts are common in pregnancy. Okay, moving on to the last part, that is breasts. So in pregnancy there is hypertrophy of breast. So fat in the breast also increases, ducts proliferate and alveoli proliferate. So increase in fat is due to increase in insulin. Okay, since there is insulin resistance in pregnancy, the amount of insulin also increases, due to which there is deposition of fats. Proliferation of duct is mainly due to estrogen, and proliferation of alveoli or increase in number of alveoli is due to estrogen as well as progesterone. Okay, now there are some sebaceous glands which are present in the breasts, but which are not normally seen to the naked eye if the woman is not pregnant. But in the pregnancy, these sebaceous glands hypertrophy, and they are called as Montgomery tubercles. Okay, and the colostrum secretion, colostrum production starts by 12 weeks, but it's not secreted. It's secreted after the childbirth, delivery, but its formation starts by around 12 weeks. Okay, and one important point about colostrum is that it has higher nutritive value than the breast milk, except it is the fat content, the carbohydrate content, and the potassium content is lower as compared to milk. The rest, all the nutritional value is higher. Okay, so that's all for today. We'll continue with the remaining systems from tomorrow, and we'll probably also discuss the pathology. Like if we are dealing with metabolic changes, we'll also see diabetes in pregnancy. That's my plan for now. Let's see. Chalo, till then, enjoy and keep studying. Bye bye.